I am Maria Escolar, Chief Medical Officer at Forge Biologics. I'm also a professor of pediatrics at the University of Pittsburgh. Today, I'm going to talk to you about disease correction with EPX-101, intravenous AAV gene therapy for the treatment of infantile Krabbe disease. Infantile Krabbe disease, as you all know, is caused by the deficiency of galactosylceramidase that results in very rapid demyelination of the brain and the peripheral nervous system. I will be focusing in the infantile onset from 0 to 12 months. That is the most aggressive form, and it affects 90% of the patients. The average untreated patient dies by 2 years of age. The current standard of care for the pre-symptomatic patients is hematopoietic stem cell transplantation. Unfortunately, this transplant slows progression and improves outcomes, but is not curative. In the infantile Krabbe disease, you see initial irritability, dysphagia, progressive spasticity, cognitive deterioration, blindness, deafness, seizures, dysautonomia, severe apneic episodes, and there is an unfortunate delay in diagnosis of about 3 to 4 months, and this comes from a natural history of 124 patients. In a natural history of 114 patients with infantile onset between 0 to 12 months, we were able to demonstrate that there is disease evidence in most of the asymptomatic patients. And this evidence of disease you can see in MRIs of the brain and spine, in abnormalities in nerve conduction velocities, auditory brainstem responses before they become clinically symptomatic. These are ideal candidates for transplant because while they have these abnormalities, they still have not shown any symptoms, and we still are able to rescue some of this initial demyelination. Once they have progressive spasticity with loss of muscle tone after 12 months, this starts to be too late. Other signs of advanced disease and poor prognosis are irritability, hypotonia, persistence of primitive reflexes, shallow breathing, prolonged apneas, visual tracking difficulties, eye fluttering, aspiration pneumonia, orthopedic complications. For example, they can have hip subluxation or dislocation, as well as scoliosis. And dysautonomia is another poor prognostic sign. So what is umbilical cord blood transplantation? It's a type of transplant where the new hematopoietic system comes from blood that is drained from the placenta. You get then white cells that are carrying the missing enzyme. The enzyme is secreted and is taken by the deficient cells in the brain. Umbilical cord blood transplantation is readily available, which is important in this disease that progresses so quickly. You can find compatible units for most of the population. The outcomes have been excellent, with 100% of survival for patients receiving reduced toxicity and reduced intensity chemotherapy. And this has an N of 28 patients treated in the last 10 years at UPMC site. When you add other diseases and in a cohort that is now over 60 patients, the survival is 95%. UCBT, which is the abbreviation for umbilical cord blood transplant, is the preferred treatment for asymptomatic babies, and this was published and well known since 2005 when our group published the short-term outcomes of this treatment. What we found out is that if you did it prior to symptom manifestation, it resulted in significantly improved neurologic outcomes. However, after symptoms develops, there is no difference with the natural history except that their survival is prolonged. Some of these short-term outcomes in transplanted neonates included near normal or normal cognitive function, but variable motor outcomes. Later on, there was another research that lasted over 15 years showing the long-term outcomes of this same cohort plus additional patients, in which it clearly demonstrated that there was a slow progression of motor disease due to peripheral neuropathy. And this is a summary of that study published by Wright et al. In 2017, where 18 patients were followed. 3 patients are able to walk independently, 7 walk with assistive devices, 3 were unable to walk, and 5 progressed and died, unfortunately. The good news was that there were no new signs of demyelination in the brain. And the sad news was that there was slow progression of the peripheral neuropathy that translated into plateauing of motor function. And you can see this clearly in these two figures on the right side, where in the upper one, you can see how cognitive development was either normal or near normal. This is the developmental age plotted against the chronologic age, and the gray lines is the range of normal. In the lower one, you're looking at motor development. And so you can see that at around 1 to 2 years, there is a plateauing with progression of motor disability, especially right after teenage years. So the conclusion was that transplant improved survival and quality of life up to about 10 years. And then there's disease progression. FBX101 is a galactosyl ceramidase gene replacement therapy. It is administered intravenously one time and is done after hematopoietic stem cell transplantation. Our preclinical data shows that FBX101 is safe and corrects both the brain and the peripheral nervous system in the mice and dogs. Just to show what these vectors do, they penetrate the membrane, then the increasing acidity causes release of the pentons, which are the little spikes. Then this virus disassembles and delivers the DNA into the nucleus through the nuclear pore, where the DNA is then translated into mRNA, and then protein is made, and it can be then secreted and taken by other cells. This is work done by Dr. Wenger, published in 2020. We collaborated with him in showing that FBX101 can improve survival when delivered after transplantation in the Twitcher mice. On the left side, you're seeing the synergistic effect of this combination of FBX101 with bone marrow transplant. The red line is the untreated affected mice. The black and dotted line is either bone marrow or gene therapy alone. You can see there's not much difference, but the synergistic effect is evident in the blue survival line. They continued and did also a dose-dependent survival benefit with AAV after transplant in Twitcher mice. The green line is showing you about half the target dose, and the brown and the purple lines are showing you 1/10 and 1/100th of the dose, so you cannot see much of an effect there. And then the last blue and dotted green lines are showing that there's not much difference between 4 times the dose and our target dose, which is the one in the blue line. Here on the left side, we're showing the GALC activity in orange. You see the wild type levels, and in this kind of dark blue with an orange outline, you're seeing the bone marrow transplant combined with the gene therapy. And you see a very, very large effect. So these bars are very, very big. But when you compare wild type with our target dose, it looks pretty similar. And that would be the black and the orange. On the right side, you see the histopathology now of the peripheral nerve of the wild type on the left upper corner, and then on the right upper corner, the twitcher, if it's untreated, you can see a lot of edema in those fibers. In the lower left quadrant and the lower right quadrant, target and 4 times the dose, you can see that these peripheral nerve fibers look more normal, more similar to the upper left quadrant of the wild type. The dogs that were treated, which was moving into a larger animal model, this was done by the group of Alison Bradbury and Charles Feet at the University of Pennsylvania. The left dog is the Krabbe dog that has not been treated. This dog was sacked at 14 weeks because of severe pelvic girdle weakness. In the middle, you see a dog that was treated with only AAV. This dog was sacked at 42 weeks, which is when he reached the human endpoint. You can see that even though it's a little bit stronger than the other dog, he still has weakness. And in the last video, you're going to see the one that has the combination therapy that was sacked at 104 weeks, mostly because of the design of the study, not because there were any abnormalities in the neurologic exam. This is just to show you a little bit about the dog. This is unpublished data. And on the bars on the top are showing the nerve conduction velocity. Normal is on the right, the combination therapy is on the left, and it shows how it normalizes the nerve conduction velocity in the Cravet dog. And in the lower part, you can also see how it corrects the peripheral nerve disease. You see much more normal fibers as compared to bone marrow transplant only. Okay, so on the right side, you see FBX101 and BMT, how it reduces white matter loss in GLD dogs. If you focus just on the first one, which is the normal, and the second one, which is the GLD, showing more demyelination around the ventricles. And this is where you see areas of high intensity signal. While the dogs that received the combination therapy had less demyelination in the brain. And then the last one is just the AAV alone. This is just to show you the next study we did, which was a GLP rat toxicology study that evaluated several doses administered after transplantation. The other thing that had to be done was a pilot study in which the rats were transplanted with this same reduced toxicity regimen that you see in the bottom that has hydroxyurea, fludarabine, busulfan, and tacrolimus. So the first group just received vehicle, then you have the three different doses, the low, target, and high dose. And the last group has only AAV. They go through the pre-transplant conditioning, the transplantation on the A-7, and then intravenous AAV. After that, the same immune suppression regimen using humans was actually used in the mice. And they were sacked at different time points at 831 days and 182 days. So these allow us to choose the right dose based on any type of toxicity that was seen with the highest dose. That was 2.5 above the optimal target clinical dose of 8 times 10 to the 13 GCs per kilo, and one log higher than the proposed starting dose, which is 3 times 10 to the 13th. So then we designed the clinical trial for patients, and it's an open label dose escalation phase 1/2 clinical trial of intravenous FBX101, the liver after transplant. There are 2 cohorts, 3 with the low dose and 3 with the high dose. The study arms are subjects that are eligible to receive transplantation. And then this is followed with this single intravenous infusion of FBX101. The criteria is that they have to have the diagnosis of infantile Cravet disease. The age at screening has to be 1 day to 12 months. And they must have adequate organ function at the time of screening. The primary outcomes is determination of safety, and this is based on the development of unacceptable toxicity defined as occurrence of 3 or more unanticipated grade 3 or higher treatment-related toxicity. There are secondary outcomes, which are improvement of the probability to achieve independent sitting, improvement in gross motor function as measured by the PDMS2 at 12 and 24 months. And we have some exploratory biomarkers, peripheral nerve conduction, velocity, auditory brainstem responses, brain MRI changes, cytosine reduction, and increase in GALC activity beyond what you see in transplant. We have administered the treatment now to 2 patients, resulting in excellent safety profile. This is the first time in human trials where patients are treated with AAV gene therapy during full myeloablation, alleviating the immune challenges and creating a much safer environment for gene replacement. These patients were infused on days 25 and 29 post-transplant, respectively. The patients did not show any elevations in liver function test after the infusion, and both had normal liver ultrasounds. There are no clinical signs and symptoms of dorsal root ganglia involvement, and in both patients, the nerve conduction velocities remain normal. So in summary, early unrelated cord blood transplant provides ongoing replacement of the deficient enzyme, improving and halting disease in the brain. And unfortunately, peripheral nerve disease is progressive and causes severe motor disability. The preclinical data supports correction of both brain and peripheral nerve disease when FBX101 is delivered intravenously after hematopoietic stem cell transplant. FBX101 has the potential to augment the transplant effect in both the brain and peripheral nerve, as well as prevent the immune response to AAV gene therapy when given after cord blood transplantation. We're opening a new site for enrollments. It's at the University of Michigan, where they will be using reduced toxicity conditioning for UCBT. They will be opening also an additional trial to include expanded age criteria. All trial activities are being transferred from the University of Pittsburgh Medical Center to University of Michigan. Forge will be opening an additional site in California. And the PI of this trial at the University of Michigan would be Dr. Mark van der Lugt, who's a pediatric bone marrow transplanter. I would like to acknowledge our collaborators that were involved in the preclinical studies while I was at the University of Pittsburgh, the neurodevelopment and rare disorder staff, Dr. Sabolch, who is the transplanter and developed the reduced toxicity regimen for this project, as well as Dr. Poe and our collaborators in the preclinical studies listed here, especially Dr. Wenger, Alison Bradbury, and Mike, Joe and Dieter, who work diligently with the measurements of the enzymes, and Dr. Gray, who helped us in some of the design. I want to thank also all the families of Krabbe patients, Krabbe Connect, KTRN partners for Krabbe Research, and the Dana Foundation, and our colleagues at Cornell University, Stephen Kaminsky, Dolan Sandy, and Neil Hackett. Thank you very much. If you have any questions or would like to contact us, please feel free to email our Forge Biologics mailbox or reach out to Michelle Salvo, our patient advocate. Thank you very much.